Usually, when we think about a medical diagnosis, there's this expectation of precision, It feels like engineering or something.
Right. Very binary.
Exactly. You break your arm, the x-ray shows a jagged white line, and the doctor points at the film and says, there it is, broken. Clean and simple. But step into the surgical intensive care unit, and that entire x-ray machine metaphor just completely falls apart. You're looking at a physiologic landscape that is so murky, shifting minute by minute. Fixing one organ system can...
Inadvertently crash another one, yeah.
Yeah.
It is the definition of high-stakes, diagnostic, muddy waters. The surgical ICU is where human physiology is just pushed to absolute limits, often by the very interventions designed to save the patient.
Yeah, which is terrifying but fascinating. So, welcome everyone, whether you are a medical student prepping for rounds, a young professional, or just a deeply curious self-taught learner, today's deep dive is for you. We are looking at a really comprehensive stack of excerpts from the Surgical Critical Care Handbook, edited by Dr. Jamil Ali.
It's a fantastic resource. It really is. And our mission today is to provide a high-yield, clear, and scientifically grounded summary of the core physiological crises you'd encounter in the surgical ICU. We're going to bypass the unnecessary jargon, provide some practical clinical examples, and really equip you with the mental models needed to understand these life or death scenarios. I mean, that's the goal, right? To get past the superficial summaries and get into the raw physiology.
Okay, let's unpack this, because a huge part of surviving the ICU actually begins before the scalpel even touches the skin. We have to look at assessing who is at risk before surgery even begins.
Yeah. And the authors lay down a foundational concept right in the first chapter, which is that elective surgery is essentially planned trauma.
Planned trauma. That's a wild way to think about it.
But it's true. I mean, the human body doesn't know the surgeon is trying to cure a disease. The nervous system and immune system simply register tissue damage, blood loss, massive fluid shifts, the introduction of foreign materials.
So the body just reacts to the insult.
Exactly. It mounts a massive neurohumoral and inflammatory response to survive what it basically perceives as an attack. So, to predict how a patient will handle this planned trauma, clinicians use predictive tools to measure their physiological reserve.
Like the ASA classification, right?
Right, the American Society of Anesthesiologists classification. It scales from ASA 1, which is a completely normal, healthy patient, up to ASA 5, a moribund patient not expected to survive 24 hours.
But the handbook makes it pretty clear that a broad score like that isn't really enough anymore, especially with our rapidly aging surgical population.
No, it misses the nuances. That's why the Revised Lee Cardiac Risk Index is heavily featured. It isolates specific red flags like a history of ischemic heart disease or congestive heart failure or preoperative insulin-dependent diabetes. And with patients over 80 making up nearly 15% of ICU admissions now.
Which is huge.
Yeah, it's massive. Those comorbidities are the rule now, not the exception.
And that demographic shift totally changes the approach. The text spends a lot of time on this term, homeostenosis, which really explains why an elderly patient's baseline is so different.
Right. Homeostenosis is essentially the age-related stiffening and narrowing of all organ systems. Over a lifetime, genetic degradation, cumulative oxidative stress, it all causes the body's systems to lose elasticity. The heart gets stiffer, blood vessels lose compliance, the lungs don't expand as easily.
The reserve shrinks.
Exactly. The physiological reserve shrinks.
So an 85-year-old might look perfectly fine just, resting in a chair reading a book. But the moment the planned trauma of surgery happens, their cardiovascular and respiratory systems just hit a wall.
They literally cannot stretch to meet the massive metabolic demands of healing. They lack the buffer to absorb the shock. And this lack of reserve extends to the central nervous system, too. The handbook notes that postoperative delirium occurs in up to 50% of elderly surgical patients.
50%? That's incredible.
It's basically an acute state of brain failure. You see fluctuating mental status, severe inattention, disorganized thinking.
I want to stop here for a second because I read this section on delirium. And wait, isn't it counterintuitive that taking away pain meds makes delirium worse? You'd think heavy narcotics, like the opiates we give for pain, are what caused the confusion in the first place.
What's fascinating here is that assumption actually leads to a devastating physiological feedback loop. While opiates do have cognitive side effects, untreated pain acts as a massive physiological stressor.
Oh, I see.
Yeah, when a patient is in agony, it drives a systemic stress response. The body just floods with catecholamines, adrenaline, and noradrenaline, along with cortisol. This chemical storm completely fries an already vulnerable homeostenotic brain.
So they're basically marinating in adrenaline.
Right. The untreated pain actually creates or worsens the delirium. But then doctors observe the delirium, assume it's drug-induced, and restrict the pain meds even further.
Which just causes more pain, a bigger stress response, and a worsening cycle. Wow. Okay, so moving forward, imagine our vulnerable patient survives the surgery. Or maybe they just arrived via the ER with severe trauma. We run into the silent killers, shock and gas exchange failure.
The two most immediate systemic threats, yes. The failure to deliver oxygen and the failure to clear metabolic waste.
Now, TV medical dramas always show shock as just, low blood pressure, alarms blare, someone yells, push fluids.
And that is so dangerously incomplete.
Yeah.
Shock is heavily misunderstood. The Handbook defines it as a generalized state of cellular hypoperfusion.
Meaning the tissues are starving for oxygen at a microscopic level.
Exactly. A patient can have a totally normal blood pressure reading on the monitor and still be dying of shock. When cells are starved for oxygen, they switch to anaerobic metabolism.
Which is like the cell's emergency backup generator, right? It keeps the lights on, but it produces a toxic byproduct, lactic acid.
Right. And left unchecked, that acidic environment destroys the cell. This is why critical care goals go far beyond a blood pressure cuff. Clinicians use markers like lactate clearance or a metric called the base deficit.
Base deficit. It sounds like an accounting term. How does that help?
Well, think of the body's bases, like bicarbonate, as an alkaline buffer reserve. When cells churn out massive amounts of lactic acid during shock, the body uses those bases to neutralize the acid.
So a rising base deficit means you're burning through your alkaline reserve.
Exactly. It proves the cells are starving and switching to anaerobic metabolism, often hours before the blood pressure ever drops.
You're monitoring the cellular exhaust fumes to see if the engine is failing. I love that. And that ties into the other killer, gas exchange. The texts look at the dynamic between carbon dioxide, CO2, and oxygen, O2, using two cases. One patient with COPD who retains CO2, and one with pulmonary fibrosis who has O2 diffusion failure.
And this highlights a critical rule. Derangements in CO2 clearance can directly lead to derangements in oxygenation, but derangements in oxygen do not affect CO2 clearance.
Okay, let's use a real-world analogy for our listeners here. Imagine the lungs as a two-way shipping port. CO2 is the outgoing cargo, the waste we need to export. O2 is the incoming cargo, the vital supplies we need to import.
I like this. And the physical space in the harbor, the alveoli, the tiny air sacs, is strictly limited.
Right. So if the outgoing cargo ships, the CO2, start backing up in the harbor, like with our COPD patient who can't fully exhale, the harbor gets completely clogged. And because it's full of CO2 ships, the incoming O2 ships literally cannot dock.
Yes. The physical space is occupied. A failure to export CO2 directly causes a failure to import oxygen.
But the reverse isn't true. If an incoming oxygen ship sinks out at sea, like with the pulmonary fibrosis patient, the outgoing CO2 ships can still leave the harbor just fine.
Exactly. Plus, CO2 is highly soluble. It diffuses 20 times faster than oxygen. We can connect this to the bigger picture. This is why intensivists focus so heavily on CO2 clearance and mechanical ventilation mechanics.
Using tools like CPAP or BiPAP.
Right. It's not just about pushing oxygen in. It's about altering the pressure gradients. You use positive pressure to physically stent open those collapsing airways and force the trapped CO2 out. You clear the docks so oxygen can finally reach the starving cells and reverse that shock we were just talking about.
Wow. Okay, so we've looked at systemic failures. Here's where it gets really interesting, though. Sometimes the most dangerous crises are highly localized, hiding in a single injured limb. Extremity trauma.
Yes. The ticking clock of compartment syndrome. You can perfectly resuscitate the heart and lungs, but if you miss a crushed tibia, they could lose their leg or their life.
Because of the fascia, right.
Right. Muscles in the lower leg and forearm are grouped into compartments surrounded by fascia, which is a tough, completely unyielding membrane. It's like a tight sausage casing.
It doesn't stretch at all.
Not even a little. So if pressure builds up inside from bleeding or swelling, it eventually exceeds the pressure of the arterial blood trying to flow in.
The arterial inflow hits a wall.
Exactly. The capillary beds collapse, leading to rapid muscle ischemia and necrosis. The muscle tissue dies. And as it dies, it releases myoglobin into the bloodstream, which is highly toxic to the kidneys. It causes acute renal failure.
And the medico-legal aspect here is huge. Missing a compartment syndrome diagnosis is a leading cause of medical litigation because losing that limb is entirely preventable if caught early. But how do you catch it if the patient is sedated and can't tell you they're in pain?
That's the challenge. Diagnosis is largely clinical, looking for pain out of proportion to the injury. But in the ICU, you often have to actually measure the compartment pressures with a needle. And the crucial metric isn't the raw pressure, it's the delta P.
Delta P, which is the diastolic blood pressure minus the compartment pressure, right? Why the diastolic?
Because diastolic pressure is the minimum driving force keeping those capillary beds open during the resting phase of the heartbeat. If your delta P drops below 30 millimeters of mercury, you are in the danger zone.
And the treatment is immediate, right? Emergency fasciotomy.
Yes. The surgeon cuts the fascia, often in an H shape, to physically release the pressure.
Brutal, but life-saving. But compartment syndrome isn't the only localized trauma threat. There's also fat embolism syndrome, or FES, from long bone fractures.
Yeah, FES is a severe complication. The initial trauma physically disrupts the fat in the bone marrow, and microscopic fat droplets enter the venous bloodstream.
The book mentions diagnosing this with GERD's criteria, right? Major criteria being hypoxia, central nervous system depression, like a coma and a petechial rash. But how do fat droplets cause a rash and a coma?
It happens in two phases. First is the mechanical phase. The fat droplets travel to the lungs, blocking blood flow and causing hypoxia. But some squeeze through to the systemic circulation.
Oh, wow.
Yeah, they travel to the brain, lodging in the cerebral microvasculature, causing microscopic strokes. That's the coma.
Wait, really? They literally act like tiny blood clots.
Exactly. And when they lodge in the tiny capillaries of the skin, platelets rush to those blockages and get consumed, causing microhemorrhages. That's your petechial rash. But then comes the biochemical phase, 24 to 72 hours later. The body breaks those fat droplets down into free fatty acids.
Which are toxic, right?
Highly toxic to the lungs. It triggers massive inflammation and acute respiratory distress syndrome.
That's terrifying. From a broken leg to multi-system failure. All right, so moving away from blunt force trauma, the ICU also handles trauma that destroys tissue invisibly from the inside out, thermal and electrical trauma.
Right. These are uniquely deceptive. With electrical injuries, it's all about voltage. High voltage, which is greater than 1,000 volts, creates a devastating iceberg effect.
Because electricity seeks the path of least resistance, right? Like blood vessels and nerves.
Exactly. The visible skin burn might look tiny, but massive deep tissue destruction has occurred along the path of the current. The muscles are basically cooked from the inside out.
Which makes them highly susceptible to compartment syndrome.
Absolutely. And since the current often passes through the chest, you have to do continuous cardiac monitoring for delayed arrhythmias.
And then there's the physiological opposite. Cold injuries, frostbite. The texts break this down into distinct phases. Phase 1 is freezing.
Right. Ice crystals form, causing severe cellular dehydration.
So what does this all mean for the clinician on day 1? If a patient comes in with a frozen hand, how does the doctor balance the need to thaw the tissue with the danger of making it worse?
This raises an important question because phase 2, the thawing phase, ironically triggers a massive reperfusion injury.
That's the cruel paradox.
It really is. You restore blood flow, bringing fresh oxygen to severely damaged cells, but their mitochondria are broken. So instead of making energy, the oxygen produces massive amounts of oxygen-free radicals.
So normal oxygen actually acts as a toxin.
Exactly. The free radicals shred the cells, cytokines cause inflammation, and platelets clump together, forming microclots that block the newly opened capillaries all over again. The very act of restoring blood flow masks the cellular destruction beneath the surface.
That is just... It's incredible how complex this is. Well, we have covered an immense amount of ground today. As promised for our medical learners, let's do a quick review exercise. Listener, imagine you are evaluating a polytrauma patient with a tibial fracture. They develop worsening pain out of proportion to the injury, but their distal pulses are still normal. What surgical emergency must you suspect, and what physiological metric helps confirm it?
I'll jump right in here. The presence of pulses doesn't rule it out. You must suspect compartment syndrome, and you confirm it by measuring the compartment pressures to calculate the delta P, the diastolic pressure minus the compartment pressure. If it's under 30, it's a surgical emergency.
Perfect. To wrap up, I want to leave you, the listener, with a final provocative thought from Chapter 14 of the Handbook. It dives into the profound ethical considerations of all this.
Yeah, the ethics of critical care.
We have all this modern ICU technology, mechanical ventilators, massive transfusion protocols, advanced pharmacology. We have this unprecedented ability to artificially override homeostasis and keep the human body alive.
We can sustain cellular perfusion long past the point of natural failure. Yeah.
Right. But at what point does the technological triumph of sustaining cellular perfusion cross the ethical line of doing more harm than good to the human being? When does the planned trauma of our interventions just become trauma?
It's a heavy question. You have to treat the whole patient, not just the physiology.
Exactly. Something for you to mull over next time you're on the floor. Thank you for joining us on this deep dive into the Surgical Critical Care Handbook. Until next time.